I would like to welcome everyone to today's webinar, Conversations That Count, Improving Care for Patients with Serious Illness Through Engagement of Providers and Patients. I'm Andrea Greenberg, Communications and Partnerships Associate at the Schwartz Center for Compassionate Healthcare, and your moderator for today's session. The Schwartz Center for Compassionate Healthcare is a national leader in the movement to make compassion a vital element in every patient-caregiver interaction. Before we begin the formal presentation, let's go over a few details about the webinar. The Schwartz Center Compassion in Action webinar series is funded in part by a donation in memory of Julian and Eunice Cohen. Today's program will be 60 minutes. The first 45 minutes will be presentation, followed by a 10-minute question and answer session. Today's program is being recorded and will be available on the Schwartz Center website a week after the session. Please note that attendees are participating in listen-only mode, but can interact with the speakers by using the questions pane, which should be appearing on your screen. If you have questions, please just type them into the questions pane and send them to us, and we will address as many of them as we can at the end of the presentation. We will be polling the audience during today's presentation, and we hope that you'll participate in this interactive measurement tool. As you exit the webinar, you will receive an electronic survey that we ask you to take a minute to complete so that we may capture your assessment of today's program. Your feedback is really important to us. And now it is my pleasure to introduce my colleague and our host for today's session. Dr. Beth Lown is an Associate Professor of Medicine at Harvard Medical School and the Medical Director of the Schwartz Center for Compassionate Healthcare. Welcome, Beth.
Thank you, Andrea. Good afternoon, and thank you all for joining us for this session on compassionate collaborative care, or what we're calling the Triple C. In January, during the first webinar of this 2016 series, I introduced the Triple C model and its associated attributes and behaviors. We discussed some of the science of compassion and empathy and discussed why compassion is a source of reward and an antidote to burnout. The framework shown on the slide now explains some of the key values and the skills that help us offer compassionate collaborative care to patients, to families, colleagues, and coworkers, while also sustaining ourselves and our sense of happiness and meaning in work. A full description of these skills is available on our website. Each month, we've been offering a webinar by experts on different aspects of the Triple C framework. During today's session, Conversations That Count, Improving Care for Patients with Serious Illness Through Engagement of Providers and Patients, you'll hear an engaging story of discovery, occasional failure, and growing success in improving care for patients with advancing serious illness while achieving the Triple Aim improvement goals. Dr. Shulman and her colleagues' strategy combines data, education, and workflow optimization to dramatically improve advanced care planning. In order to take care of the next steps and engage providers, patients, and families in difficult conversations, Dr. Shulman and her colleagues teamed up with the Serious Illness Conversation Project to provide a structured tool and coaching for their teams to push their organization closer to providing goal-concordant care for their patients with serious illnesses. The results were measurable and dramatic, and while they still have a long way to go, they're really seeing changes in their practice that go beyond metrics. So by today's program, you will be able to identify the importance of conversation as a part of comprehensive advanced care planning and how challenging this can be for providers. You'll also be able to understand the need for a multifaceted approach to education and training of primary care teams and the importance of team-based approach with diversity of skills for this kind of planning. So today we're honored to have as our speaker Dr. Eliza, or Pippa, Shulman, a primary care physician at Harvard Vanguard Medical Associates, Atrius Health, and also an instructor in the Department of Population Medicine at Harvard Medical School. Welcome, Dr. Shulman. I'm going to turn the program over to you.
Beth, thank you so much, and Andrea as well. And thank you to the Schwartz Center, who have been such wonderful supporters of our work and also always supportive of the emotional side of medicine as well. So today, I'm really going to tell you a story. And we're going to talk about the journey that our organization took to get where we are today and how we leveraged the local, regional, and national priorities really to our own advantage to try to focus people on advanced care planning and end-of-life care and care of serious illness for our patients. This is not without challenges and not without barriers, and I'm going to really try to share where we encountered those, maybe so you can anticipate them in your own system or help us overcome some of the barriers that do exist. Beth mentioned the multifaceted approach, and I think this is really key. Feeling like advanced care planning is the right thing to do isn't enough. The organization has to be speaking a common language. People have to have a baseline level of education and training. And you can't have one person that is feeling passionate about this. You have to do this all together. And I'm going to touch on all of these things. As I mentioned, I like to start with a story. I do have permission to tell this patient's story, but her name is not Stella, and that's not her on the screen. That's actually my friend's grandmother, but I always like to have a visual. Stella is a patient that I met very early in my training, and if you've heard me speak before, you've heard me speak about her. She had very bad lung disease and was hospitalized 6 or 7 times within an 8-month period and came in for a routine post-hospital discharge visit, which we are measured on, making sure we get that visit done. She came in with her husband, and when I walked in the room, it was really not ideal. They had perched this tiny 82-pound woman on top of the exam table. She had her oxygen hooked up. Her feet were kind of dangling. She seemed like she was gripping the side as though she might fall at any moment. Her husband was kind of off in the corner, and the whole thing just looked off, and she didn't look well or happy to be there. And so I got her off the table, and I got her into a chair, and the first question I asked was, Stella, what was that hospitalization like for you? And she said to me she never, ever wanted to go back. And that was really a new starting point for a conversation that I thought I was having with my patients, but that I hadn't really been having with my patients. And from that moment, we really changed the trajectory of Stella's care. I spent time with her and her husband to figure out what did they understand about her illness and where she was going, and what were her goals and her preferences for treatment. And although certainly she'd been asked in the past about code status and healthcare proxy, I hadn't gotten to the meat of what really mattered. And what mattered to her was to be able to be at home near her family and to allow her husband to do his tinkering and not have to keep making trips to the doctor's office that left her tired for days. And so we were able to make that happen for her. And she had another many good months in her home with home hospice services, family all around, and really what we think of as a, quote, good death, but a death that really she wanted under her terms. And that's really the important part. Death is a scary word when I use it often in presentations, but I do like to remind people that the world death rate is holding steady at 100%, and many are suggesting that this high mortality rate represents a failure on the part of our healthcare workers, but I like to talk about death to try to take some of the air out of it. If you've ever seen B.J. Miller do his TED Talk, I think he's got a wonderful way of talking about this that just helps everybody say, all right, we're talking about something hard, but we all have feelings, and let's explore that a little bit more. So I want to explore your thoughts a little bit. So at this point, I'd like to turn it over to Andrea for our first polling question.
Yes, thank you, Dr. Shulman. Okay, so our first polling question should be appearing on your screen, and it reads, have you assisted with advanced care planning for a client, patient, or family member? Please select yes or no. So go ahead and use the poll pane that should be on your screen. I see we have some answers coming in, so I'll keep them coming. Okay. Great, almost there. Okay, fantastic. Okay, so we have a good response, so let's close the poll and share the responses. We have 94% that said yes and 6% that said no. Dr. Shulman, any thoughts on these results before we launch the next polling question?
Well, I'm certainly delighted to see. I think we have a little bit of a stacked audience, which is good, and I almost wish we'd been able to break out client and patient versus family member, because I think more and more we're having these conversations with family. I'm glad that you're all assisting or helping folks start these. Let's ask the next question.
All right, fantastic. Our second polling question should be appearing on your screen and reads, have you participated in advanced care planning for yourself? It looks like we have quite a few answers coming in. All right, fantastic. Thank you all very much. We have a good response, so let's close the poll and share the responses. We have 77% from our audience that said yes, and 23% that said no. Dr. Shulman, any thoughts on these results before we jump back into the presentation?
Certainly. So first, I'll say that's actually a really great response. When I do this talk in groups, usually it's about 50-50, or less than half of people have done it themselves. So I think this might be a selecting crowd, but I'm interested that over 90% had helped someone else, but almost a quarter, have not done it for themselves. And I say that because whenever you're undertaking this work in your organization, I think it's helpful to figure out how can your organization support their own employees at doing this, because it makes you better at doing it for clients and patients. So why do we care about this so much? We know that there's really a disconnect in the last year of life between what the patient wants and what the reality is of their care. And I'm sorry that a lot of this language is doctor-focused. It's a self-selecting bias, my apologies. Patients and families really do want to talk about advanced care planning, but predominantly doctors are reluctant to discuss or feel that they don't have time. Patients really want to decrease the intensity of their care, particularly when they're aware that they may have a poor or short prognosis. But we know that the majority of Medicare spending happens in the last 12 months of life. And if you start to dig into that data, the numbers are even more concerning, that patients have a lot of care transitions in the last months of life. They are having a lot of hospitalizations, ICU stays, procedures, etc. We also know that patients want to die in their home, and the majority of them, that we're not able to make that happen for them. We also know that although a third of patients have a living will, which I'd like to see that number higher, it's often not available when needed. We know that there are pockets of the country where some great efforts have gone on to increase those numbers, and as well as get them into the hospital setting, but we know we need to do a better job. We also already talked about folks in the hospital and almost 20% in the ICU. There's a huge geographic and actually racial and ethnic disparity in how many patients use their Medicare hospice benefit. And so this is, I think, really interesting data. And we know that in Massachusetts, 40% of hospice patients have a length of stay on the hospice program of 7 days or less. And there's further data that shows that only about half of patients with serious illness are ever offered hospice. And while hospice, may not be appropriate, we know that the numbers are even worse for just general palliative care, and that we have a lot of work to do. Now, it's not all the patients, right? There's a lot of clinician and physician barriers to advanced care planning. There's personal discomfort or fear with talking about end of life with patients. And sometimes that's driven by our own anxiety, and sometimes that's driven by a feeling of not wanting to take away hope, that there's some fear that that may happen. Almost every clinician I talk to cites time as a big barrier, and I agree that it is. Feeling that you can't bill for it, even though we've been able to bill for it for some time, and now there's new billing codes that make that possible. There's also, ignorance is a strong word, but there's a lack of understanding, that there are steps, that this is a process, that a healthcare proxy is not the same as a living will, is not the same as a MOLST, is not the same as, just a conversation around goals and preferences. And so that sometimes makes the topic feel mushy, and that it's not a concrete task to complete, like doing an algorithm for a chronic disease, for instance. And there's also concern about what if a patient changes their mind, that if we don't have this conversation at exactly the right point, what if we have information that changes? And everyone should change their mind and should evolve and grow. So in our organization, when we were thinking about these barriers and thinking about how to really overcome them, we had some things working in our favor. There were some Massachusetts actions that were helpful to us. So there was the relicensing requirement that physicians needed to have 2 hours of end-of-life continuing medical education. There were some DPH regulations around talking to patients who had a limited life expectancy about palliative care and end-of-life choices. There was the End-of-Life Commission in Massachusetts, which produced some wonderful data and reports. In our organization, we had our internal data around the frankly low numbers of patients who had healthcare proxies or other advanced care planning. But we knew that in our population, those with an advanced and serious illness represented 1/3 of all the costs to our system. For our senior leadership, they really were focused on making sure that we had a great system of care for our patients, and particularly for our frail patients, and we were able to work with them to make advanced care planning a focus of quality efforts. We also know that one important area is in the patient engagement realm, that there were a lot of factors nationwide and even worldwide that were feeding into this that were really helpful to us. The Conversation Project, coming right out of our state, but really an active program to engage patients in how to have conversations with their families and their providers. Compassionate Choices Massachusetts, really doing a lot of great work in this area. The Institute of Medicine, which although a professional organization gets a very wide play in the lay press, really stimulated a lot of interest, and there were certainly some books by noted authors that I think helped patients drive the conversation back at us. And so for our organization, we really looked at what was our reason for action. We knew that our patients with advanced illness represent a high number of Medicare costs. We didn't look any different than any other big organization. And we knew that there was a discrepancy between what our patients were saying they wanted and what actually happens. That's that home-hospital disparity. In our organization, we did our own internal needs assessment, for lack of a better way to say it, and we saw that we did not have a consistent process for engaging patients in this or documenting if we did. So, I might have had a wonderful conversation with a patient, but if nobody else knows that I did that, it's as if it didn't happen. We know that we want to prevent harm. We want patients to receive care that's aligned with their own goals and preferences. And we also had to fight this perception that people didn't want to or know how to engage in these discussions. So we came up with a strategy, and this looks like we came up with this all at once, and I'll be honest, we didn't. We started with the top 2 boxes, clinical education and practice support, and then we added tracking results and finally realized we needed to change the conversation. And I'm going to go through a little bit on each of these so you know what we're talking about. So what does practice support mean? It means that for any clinician on the front lines, we needed to make sure that they had what they needed when they were in front of a patient to be able to do this work. So we trained what we called advanced care planning champions at each of our sites to provide ongoing support for clinicians. And we had forums of these champions to sort of share and spread best practices, including the basic training. And so that's the train the trainer model. We really tried to create this cohort of folks who were experts in this work who could serve as guidance and support for our primary care physicians and the teams. And we created standard work for not just the clinicians and the physicians, but also for medical assistants and medical secretaries, and how visits should go and prompts. And I'll show you some of those. So with standard work, there's a lot of workflows and processes in your clinic that you sometimes don't think about. So for instance, if we're doing health risk assessments prior to annual appointments, we can mail a healthcare proxy form with a little explanation. If we know that a healthcare proxy has not been done, we can hand those to patients upon arrival for their appointment, and we can help them complete and sign during the visit if appropriate. To identify the patients for whom there were gaps, our electronic medical record was able to prompt the care team to engage in some kind of advanced care planning. And then we made it easier and more consistent for how to document in our electronic medical record. So some ways that we did that, in the electronic medical record, for every encounter, a checklist will open at the top of the encounter. And because it begins with A, I think we got lucky on this one. Advanced care planning is the first item on the checklist. And so you can see a picture of it on your screen. It'll say advanced care planning documents are or are not on file. So red means there's nothing there, and green means something is there. You should go take a look. And you can actually click, that's a hyperlink, you can click and see what is on file. Now, the way to make that green is really any document. So if it's a healthcare proxy, a living will, a MOLST. And I think this group probably knows well that those things look very different and have different impact on your care, but it was a good start. We also tried to make it more consistent how we were documenting in the electronic medical record. So number one, if we were introducing different decision points or forms, you could track the document. So if I gave someone a healthcare proxy or I reviewed and verified it, you can confirm that. You can also document your conversation in a notes section that is all contained in an advanced care planning module. In addition, in the module, there's information about who the healthcare proxy is, about what their sort of overall stated goals of care are, and this information can generate a report that can be sent to acute care hospitals or other sites of care as appropriate. And so just standardizing where in our electronic medical record things are stored was a huge step, and it took a lot of work and has been really useful. Now, I'll tell you the truth that sometimes I go out and I ask people where they document, and they're still not using it, but we at least have something to drive towards. And I think we've seen some great improvement just on standardizing how we do some of this. But we know that standard work is not enough. You really have to start building your confidence and competence of your primary care teams. And so we had a series of educational opportunities and trainings that we offered CMEs and CEUs for, and this was over the course of over 2 years that we were rolling these out across all of our sites. So first, our initial one was a 2-hour, we called it Advanced Care Planning 101, and it was literally, this is what a healthcare proxy is. This is what we're talking about. This is what hospice is. I mean, really kind of going through to get everyone on a common language, using the same terms, and start to give people a framework for how this process should work. And really that advanced care planning is a process. It's not a one-time thing. When the medical orders for life-sustaining treatment were released in Massachusetts, we did a 1-hour training for all the sites just on the MOLST. We did the same thing on we saw a lot of questions on hospice. We did a Hospice 101 training. So all this training, what we started to realize, and I'll talk more about this, is that we were missing a key component, which is that, yeah, we can have medical assistants handing out healthcare proxies, we can have figure out who's going to make decisions, but when it comes to a conversation with a patient that is seriously ill, where we really need to figure out what their goals and preferences are, that we needed a guide for how to do that. And so we are now rolling out this 2-hour conversation guide, and I want to spend some time there, and I will. All of these trainings included some lecture and presentation, general didactics, really an overview of the steps, but we also showed videos. We did reflections. We had people do role play, which is very unusual for a lot of the average noon conference content. And I'll tell you that as soon as you introduce a role play, people get really nervous in their noon conference environment or in their conference room environment. But that once we got them to dive in, I think we started slow and we tried it and it worked, and so we did pretty well. I wanted to show you just a sampler of our education and training, which was really the idea to sort of set up a framework for everybody so that they understood. So this is Diane Meyer and in her work on sort of the spectrum of preventive care to when you've been diagnosed with an illness, and as your health status changes, what role does palliative care play? What role do disease-modifying treatments play? Where does hospice come in, and the importance of bereavement care? The arrows on top are really reflective of our system, so this was context-specific for us, both to show what's the appropriate action in where you are in your health status, but also where would you document this in EPIC? What does this mean, right? So that there's an advance directive, healthcare proxies we get on every patient. We offer them to every patient over 18. Women going into the hospital to give birth are asked to fill out a healthcare proxy. That's a very different conversation than an older patient with multiple chronic medical conditions whose health status is declining. We really need to have some discussion with those patients. So we really tried to make sure that we continued this framework so that each session built on the previous, but also added new material. So, we had some really positive results pretty early. We were able to get our over 80% of our primary care team members trained in just the basic advanced care planning training, and that number is actually higher now. We've been able to train folks on MOLST, which is positive, and we've seen real increases in documentation in the electronic medical record. And so you'll see in 2012, we only had 14%, this is patients over 65, 14% of our patients over 65 had any kind of advanced care planning on file, anything. And I was willing to count a lot. And that by 2015, we saw this vast improvement in what we saw. But you heard me say any advanced care planning. And so although we could have said, well, great, we've 270%, that's great improvement, let's stop there. It was really important to us to look and see what does that really mean. And so it's sometimes hard to measure advanced care planning, but it's important. And so we tried to look at other ways to do that. So one way we looked at was, all right, we know what the healthcare proxy rates are, but we also know that there's a certain segment of patients who will require advanced decision making around end-of-life care, and that's reflected in the MOLST form, the medical orders for life-sustaining treatment. And so MOLST is a new process, so we knew we were going to be starting at 0, okay? So what this is showing you is that the green bars are, again, all patients over 65 and older who have a healthcare proxy or a MOLST form. And the blue bars are, healthcare proxy form, the blue bars are MOLST. Now, we wouldn't expect all of our older patients to have MOLST forms because MOLST is really only appropriate for patients who have a limited life expectancy or who have a lot of certainty around their end-of-life decisions. And so we looked at our highest risk patients in our over 65 population, and we went from 0 to 20%, which on one hand, that's a big increase, but on the other hand, these are patients that are high risk because we know they have a high likelihood of being hospitalized. And we want to make sure that if that's true, that we're providing goal-concordant care. And so we know that that's a gap that we have to fill. And we have some ideas about how to fill that, and that's that conversation piece we're going to get to. So I'm going to try to speed up a little bit here. This next slide is, again, just another way to try to figure out how we're doing in terms of goal-concordant care. And again, same story. We saw some improvement. So we were getting more eligible patients on hospice services, but still not high enough. And so what we realized had to happen was we needed to change the conversation. And this is something that I've really felt passionate about for a long time, but I really just thought, well, if we just teach people enough, if we give people enough information, if we want it to happen, it will happen. And that's, I'm laughing because I think you all know very well that that's not true. This is hard work. And that some people are expert at having hard conversations and some people are not. I think we could all do better. And so we partnered up with Ariadne Labs to work on their serious illness care program. And the goal really is more, earlier, and better conversations with patients and families around serious illness and end-of-life care. So if you're not familiar with the serious illness care program, I highly encourage you to look into it. And so what are we talking about? First is the Serious Illness Conversation Guide, and it really is a guide. It's an 8-item sequential, and I use checklist in quotes because it's really not a checklist. I think Atul Gawande was very interested in the surgery checklist and in the Better Birth checklist, and so this felt like, well, it's a similar checklist, but it's really a process of steps. And so yes, you want to follow all the steps, but it's a little bit different than a traditional checklist. And so Atul Gawande and Susan Block from Dana-Farber teamed together to come up with this guide, and it really supports a clinician through a very structured process for discussing and documenting patients' main end-of-life concerns, issues, etc. And so what it helps generate a patient-centered discussion around what's your perception of illness? How much do patients and families want shared? Goals of care, obviously. Also, a lot of time to elicit patient concerns, understand functional status and what trade-offs they would make, and really provide a very clear path, but also well-documented path that allows us to make plans for their treatment. So before I go into our experience with implementing the Serious Illness Guide, let me turn it over to Andrea because we have another question.
Yes, absolutely. Thank you, Dr. Shulman. So the question on your screen should read, do you feel anxious talking about end of life and/or serious illness? Please select one of the following responses: never, rarely, sometimes, often, or always. So it looks like we have some votes coming in. Please keep them coming. Select one of the following answers. All right, fantastic. We have a good response, so let's close the poll and share the responses. Let's see, it looks like 3% of our audience said never, 37% said rarely, 55% said sometimes, 5% said often, and 0% said always. Dr. Shulman, any thoughts on these results before we launch the next question?
Why don't we just jump into the next question?
All right, great. We're going to launch the next question here. Okay, the next question on your screen reads, do you share prognosis and confirm patients' understanding of status prior to having a discussion? Please select one of the following responses: never, rarely, sometimes, often, or always. All right, the answers are coming in. Please keep them coming. We have a couple more moments. We'll keep the poll open just a little bit longer. All right. I have some more votes coming in. All right. Please continue sharing your answers. Just a little bit longer and we'll close the poll. All right. If you haven't answered, please go ahead and put in your answer. Okay. Great. Okay. So we've had a good response. So let's close the poll and share the responses. Let's see. We have 9% that said never, another 9% that said rarely, 17% that said sometimes, 49% that said often, and 17% that said always. Dr. Shulman, any thoughts on these results before we go back to the presentation?
Absolutely. For both of these questions, it's reassuring to see the mix of responses, and so I think you'll see there's a variation in how we all approach this topic. And I think that for the folks that said, I'm always nervous discussing this, I salute you or often nervous, because it's anxiety provoking. I am also glad to see that in this particular group, many of you do share prognosis and confirm patients' understanding prior to having that discussion. Part of our training is really around the fact that patients and families want to know prognosis, and you do not harm them by telling them that. At the same time, we need to make sure that we have shared understanding of patient status. We know that when patients accurately understand their health status, they make different decisions. And so that is the key first step, and I think we don't do that enough. And so it's why I really became singularly focused on this conversation training. The conversation training is really different, and it requires you to engage in some reflection, which is hard, and to do more role play and more talking with each other. It's interdisciplinary. We couldn't just have done this with our doctors. We wanted to bring in our nurses and case managers and nurse practitioners and PAs, and we wanted to make deliberate intermixing of the teams. And this is really different than how we've ever trained folks to do something before. One of the real, I won't call it a barrier, but we heard a lot, I already know how to do this. And we really needed to ask clinicians with a wide range of experience just to try something different. And our trainings really start out quiet. And so we just had one 2 weeks ago, and the room was full. But as we started and we opened with a reflection to reflect on difficult conversations, it was hard to get people to talk. And I often get the feeling like, you're giving me free CME, can't I just sit here and get my CME? But we have been able to really engage folks and really kind of get them moving forward using all these different tools that we have. We, for a time, actually brought in actors to be patients, which was very powerful to create that scenario where you could practice in a safe environment, really having a hard conversation with someone who is going to respond like one of your patients did. Now, we can't do that for everybody, and we've got some great materials that have been created that I think help simulate that, but we really wanted to dive in. So how do people feel when they leave the training now? So what will change for you after this training? And this is where I see our greatest path forward and have great hope in how we're doing. The first one is, I know I have room to improve my communication. To get the clinicians to admit this, I think, is amazing, quite frankly, and wonderful, because it means that they're going to practice and that they know that there's a gap, and we're going to bridge that gap. I will start to speak to my patients about their goals of care. And again, this is exciting, right? I have been in hospital environments where I've watched young physicians and other trainees be trained to ask, what is your code status? Would you like me to pound on your chest if your heart were to stop? Now we're saying we're going to talk about goals, and our clinicians are saying, I'm going to start doing this more. We'll start to have more open conversations with my patients about their long-term illnesses. We'll try to sit with my silence. We very much want to reassure patients, and often reassurance comes in the form of rapid-fire factoids or premature reassurance. It's going to be okay. But we have been teaching people to not talk, which is really remarkable, I think, in our medical environment today. We are hearing people say this is going to change the way I talk to my patients. And one of my favorites was that they were going to use it with their own family to try to elicit goals. You can use it on anybody. It's absolutely fine. But again, this was taking a group of people that said, I'm already good at this, and getting them to admit, well, I could improve. I could do better. I'm going to start to talk to my patients about this. What was training like? Eye-opening, real examples from practice. People shared real struggles. Great idea to do role-playing, which I really liked, because this is the thing everyone sort of groans when they hear that we're going to do role-playing. But I think that's how you cut through some of the discomfort in this topic. And I really also like that people saw the need to involve family in having these conversations, because patients often come in alone, and we hope, and we want to support our patients, we hope no one goes through this alone. And whether it's family or a surrogate decision maker who is a friend or acquaintance, we want to make sure that we are including those folks in these conversations when patients want and when it's appropriate. And this is different kind of feedback than we normally get. Now, certainly if you are at an organization that has and supports Schwartz rounds, I think some of the goals are really similar, or the feeling, I am supported in a different way doing this work. And I think that's really important. We present this at times. One of the goals that we present is that if you get good at this, if you have these conversations with your patients and their families, this actually improves your satisfaction with how you're providing care. And there's been studies that show this. And you have less burnout, and you're not providing care that patients don't want or that you don't feel is necessary. And so that, anytime we can increase empathy and increase people's feelings like they are moving forward and doing something good, I think that's great for our healthcare system. And so people say, well, why is this different? Why is the conversation different? I think I've presented a lot of reasons why, but one that I will add, because it's not captured in our data, is that we have allowed a space for humanity and vulnerability in this work. That advanced care planning and serious illness conversations are not just about some task that needs to be accomplished. As clinicians, as for us primary care, but also in specialty care, as relationships build with your patients, we have worries and hopes for them, just like we have worries and hopes for ourselves and our own family. And by surfacing those worries and anxieties, both for the people we're trying to have a conversation with, but also, quite frankly, for ourselves, and saying anxiety with this is okay, but that doesn't mean you can't do it, I think is critical. So in summary, we got a little bit lucky that the national, state, and local forces in our organization were aligned. That really, truly, education isn't enough. I think everyone kind of starts their initiative with education, but that you need a multi-pronged approach. That you shouldn't, be too excited when your metrics improve. You should dive in there and see is what you're, particularly for things that are hard to measure like this. As they improve, drill down. Are you improving what you actually want to improve? Are you changing care for your patients and their families? And that may mean moving beyond just counting documents and into conversations. And that I think we need to remember, and I know this organization supports that clinicians at every level are vulnerable, and we need to acknowledge and support that and provide an outlet for that as part of any training that we do. And so I thank you. I went fast so we could have a lot of time for questions. So I'm going to turn this over to Beth.
Thank you so much, Pippa. That was really helpful. And the whole program is just so well thought out and well supported. We may have some questions from the audience. I was really impressed with this notion of sharing vulnerability. And I was wondering in interprofessional settings how that goes, what it sounds like. Do people at these trainings help each other out in doing the role plays? And how does that work? Can you describe that a little bit?
Absolutely. So the other night, as I mentioned, we had a training, and we always, when we introduce the role plays, we say, if you get stuck, this is a role play, you're not in a patient room, you can stop and restart. And what was amazing is I had an actually fairly senior physician working with another physician and a nurse, and I forget who did what, but the person who was acting as the clinician in the scenario just got stuck, wasn't, kind of went down this rabbit hole and couldn't get out of where they were in the conversation and started talking about more procedures rather than goals. Mm-hmm. And one of the other clinicians said, "Stop. Look where you are. Let's come back together." And I didn't even have to say anything to the three of them. They were able to support that for each other. And I've seen that over and over and over again. And I think that's important. And we also see it because we do a reflection at the beginning, a reflection at the middle, and a reflection at the end. And by the end, everyone's talking. They want to share. They're really understanding this is different. And people are then contacting me like, I was energized by this. I am so excited that we did this.
Are they structured reflections? What do you mean by reflections?
They are. So the first, and I guess maybe not that structured. So the first reflection is we just have a question. Please reflect on your experience with talking to patients about serious illness. And they take a minute and they kind of think themselves, and then we ask for people to share. And again, most people don't want to share, have nothing to say. We have some plants that we usually use. The second reflection is after they've tried the conversation for the first time. And they've had to take that plunge into the role play or into the moment that feels uncomfortable, into trying language that they may never have used before. And so that kind of opens it up a little bit. And then we mix up the groups again, and we do it again at the end of the whole training. And so it's structured that way so that we're kind of getting and we do the second reflection is also in their small group, and then we do it in the big group so that we're really able to learn from each other in the best way possible.
That's great. It's a wonderful, wonderful way to do these kinds of trainings. So I want to just ask a couple more. I think we do have some questions from the audience, but you mentioned digging deeper into the metrics, and I was wondering how you would know if conversations were changing. I have two questions. How do you know? I mean, you're not audio taping the question, the discussions or anything like that. And so other than documenting that there is a healthcare proxy and a MOLST and that you've had the discussions, how do you know really whether these conversations in fact are training? And that was my first changing, and that was my first question. My second is it changing the number of people hospitalized who don't want to be hospitalized, the outcomes that you were sort of interested in improving? So if you can comment on both process and outcomes, that would be interesting.
Great, sure. So process-wise, part of the reason to create the advanced care planning module was so there would be a single source of truth for all information in the chart. And there's a section in there where you can actually free text and document a conversation. If you write in that section, we can generate a report to see what people are writing. So that's thing one. We can look in there and see what they're writing. We've done a lot of also brute force chart review, just looking in the assessment plans of office visits. But finally, we also know that the way we set up the serious illness conversation guide in our electronic medical record, we set it up to be incredibly easy to document based on the 8 questions. So that people could use, a tick box or they don't have to do a lot of free text. And we're actually able to see how many questions did you get through? Did you start it? Did you ever finish? And so we're actually really able to get granular.
And so after they check the box, do they write in, exactly what the responses were? Is that how it's set up?
Yeah, we have some pre-populated responses and the ability to free text in if there was a response that we haven't thought of. So we're able to see both. You're able to do both of those things.
Sorry, I didn't mean to interrupt you.
No, absolutely. As far as changing outcomes, I think we're seeing the first parts of that. We are seeing increased use of home care services and hospice services at the end of life. We are seeing some increase in our use of palliative care internally, but it's a harder question and it takes longer to look at. But we've come up with some ways that we think we'll be able to measure it better, and so that's where I'm aiming for now.
Right. That makes great sense. Okay, so Andrea, do we have some questions from the participants out there?
Yes, we do. Thank you, Beth. We have a number of questions, but before we begin, a reminder to our audience, if you have a question to submit, you may still do so. Just type your question into the questions pane, and we will answer as many as we can in the time remaining. So let's jump into some of our audience questions. Our first question is, can you discuss the scope of ownership? Is it the specialist, the PCP, or the nurse?
Oh, that's such a great question. So ownership is really interesting because when, and I really want to give a lot of credit to Ariadne and the group there, including Susan and Rochelle Bernanke, who I've worked closely with. When they started validating the guide, they did it in a specialty environment, and specifically in an oncology environment, and they've moved to other specialties in primary care as well. I really felt like I'm a primary care doctor, so I see a nail and I'm a hammer, I'm gonna hammer it. I really felt like this should belong in primary care, because if my patient ends up in the hospital with a known complication or something terrible that's happened, I should have been having those conversations way before they got to the hospital, particularly about goals and preferences. Now, I've moderated that a little bit. I do think there is some shared ownership over this. Because for us, at my organization, we're an integrated system, it's probably a little bit easier for me to see a patient's chart and be able to have clear contact with their specialist and say, this is what this looks like to me. Am I right? Yes, you're right. All right, I'm going to start this conversation now. We have also started training our specialists so that they can feel confident in making sure that they're having conversations as well. We also know that there are parts of the guide particularly that are not just limited to something that a physician could do. And so that perhaps with my patient, I will sort of do the clarification of health status and share prognosis and open that conversation up, but that my nurse can finish that with them and talk about fears and worries and trade-offs, and that can happen over time. Really, such an advantage you have is that I see my patients frequently over a long period of time, and so we don't have to do this in one sitting, although you certainly can, and that different members of the team can do different parts of the conversation. And our module helps us track what's been done and what hasn't been done. So I can, if I'm just keeping track for myself or if I'm sharing care, I can see that over time.
It's all reflected on.
Thank you.
I'm sorry. It's all reflected on the dashboard, right, Pippa?
Exactly.
Okay. Sorry, Andrea. Go ahead.
Oh no, that's all right. Thank you very much, Dr. Shulman. We have a couple more questions here. Do you have any tips about maintaining or reframing hope during difficult end-of-life conversations?
So that's great. We actually had to really think about reframing hope for our clinicians, I think. There's lots of things to hope for other than just living as long as possible. And so that was really important. And I think we looked at reframing hope towards, if we take as a principle that you don't do harm by discussing prognosis, and that patients who want to know should be told, by giving them prognosis, even a difficult prognosis, number one, it allows them to do the planning that they need to do, and also to identify the goals that are most important for them. And that is a place where hope comes from, I think. I'd be curious about what you all think. And so we've reframed it around, hope is a much bigger concept than just living forever. There's hope that I'm going to be able to have, Thanksgiving with my family, hope that I will be free of pain or maintain my autonomy. And so understanding that really allows us to have that conversation in that way.
Fantastic. Thank you very much, Dr. Shulman. We have a few more questions. One question is, we have one palliative care doctor who has been training residents where conversations occur. A large barrier, I feel, is coding for reimbursement. What do you think?
That's a great one. So I have probably three responses to this. I have worked in a couple of different settings, and I've been able to bill and get paid for this based on using traditional E&M codes and billing on time with the diagnoses, and that actually is reimbursed pretty well. For Medicare patients, there's now actually the ability to bill specifically for an advanced care planning conversation, and that's the topic of an entire other webinar, although there is some good information available online, or if you want to contact me after, I can share that with you. I now practice in an environment which is we take on much more global risk for our patients, and so that it's a little bit less of a concern. But I will tell you, and I've talked to our billers and coders, that if you are properly documenting, that you can bill by time for these conversations.
All right. Thank you very much, Dr. Shulman. We have another question here. Actually, there's time for one more question. Our final question is, have you followed up with the participants, whether months or weeks, after this training? Time limitation has always been one of the major constraints.
Absolutely. So as we have two arms to our rollout. One is training as many people as possible and learning from them. We've also, for the last more than a year, been involved in an actual clinical trial supported by the Schwartz Center to look at 3 of our sites and basically split the site in half, and half of them get trained and half of them don't, and really looking at what's different for the providers and for the patients over time. And those folks we are following up with pretty closely to dip in and say, did you try it? If yes, if not, why not? Time is a big one, I think, but it's not just about having time to have the conversation, because we've actually shown that from start to finish, the conversation guide, it can fit into an office visit, but it's when is the right time. I think that's actually an area where clinicians are feeling uncomfortable with that decision, and that was a little different than I thought. And so, is this something that we should offer patients to come back for or book a special visit for? Or how can we support folks to be doing this in the course of their regular work? And that's an area that we're diving into right now, because it's a great point. We are also finding that people really feel like they do better when they have a relationship with the patient. And again, these are primary care teams, and so that makes some sense, but we do share care, and so I'd like to see some comfort at being able to share across a team if you're seeing someone else's patient. Those are probably the 2 biggest things that we're seeing right now, and we're digging into. It's a slightly different time question than I thought it was going to be, and then making sure it's the right patients.
Oh, great. Thank you very much. That wraps up our Q&A session for today. Beth, any final thoughts to share with our participants?
I think you really touched on so many, and the participants' questions were fantastic. So you really touched upon some of the critical questions and issues that are coming up for people, and we're just going to look forward to seeing your results on your studies and seeing all of this in action and your outcomes way down the line. So really want to thank you, Pippa, for sharing your work with us. It's very, very important work, and it's difficult work, and you've just taken a wonderfully innovative approach to moving towards this goal of having people receive the care they really want to receive when the time comes. So thank you for your work and for the webinar.
Thank you. It's my pleasure to be here, and we've had it's a big team effort. I do want to say that.
So Andrea, I'll leave it to you to close up the webinar and to remind people to complete the evaluation.
Yes, absolutely. I would again like to thank Dr. Shulman for sharing her expertise and insights with us, as well as everyone in the audience for setting aside time in your busy day to participate. We also hope that you will join us for upcoming programs in the Compassion in Action webinar series. Please visit our website to see our upcoming programming and learn more about the Schwartz Center for Compassionate Healthcare and our membership program. We know you are busy, but we would very much appreciate you taking a moment to complete the electronic survey upon exiting today's program, as we value your input. Thank you, and have a great day.